So welcome everybody to this talk on our project on solar powered oxygen delivery. And thanks for the kind words of introduction. And I'll just fill in a few other presenters for what we've got on the program today. Dr. Qasim Mian, who's a R4 PEDS resident and has been involved with this project from its inception and has been playing a key management role on this study. And also Dr. Saleh Nyende, who's joining us. We'll have the pleasure of hearing from the horse's mouth. So Dr. Nyende is a Ugandan pediatrician, and so he's going to tell us the word on the street in Uganda. How easy is it to get oxygen? And so I'm going to do a little interview with him at the end of this, so you can hear a little direct feedback from the source, so to speak. But what we're going to begin with, Nick, if you could advance the slide, just to give you a sense of what we're going to go over today, we're first going to start with a bit of background on the gap in oxygen delivery. And I think we were familiar with this. It hit the news, right? When India started running out of oxygen, Brazil, Manaus ran out of oxygen at one point during the COVID-19 pandemic. And so but even prior to COVID, there was a big gap in oxygen delivery in low resource settings. Whereas here in the hospital, we can kind of plug in our nasal prongs into the wall. It's not so easy in these low resource settings. So we'll start with that. We're going to next go over our solar oxygen study, which Nick will tell us about, a large multi-center study, which is just completed in December. And then plans for scaling the technology. Since we have a scalable life-saving technology, how do we now get it to a broader audience for impact? And inshallah, if Dr. Abdullah Saleh is available, he will join us for that piece and give us a sense of how to get to scale with this project. And finally, I'm going to do an interview with Dr. Saleh Nyende, who's joining us. He's currently a pediatric nephrology fellow, but originally from Uganda, so we can hear from the horse's mouth, as I said. So with that, I'm going to hand it over to Nick. Nick, please go ahead with the next slides.
Sounds great. And I'll actually pass over to Dr. Mian, who will get things started.
Great.
Awesome. So like all our presentations in medicine and training so far, I want to start with a clinical case. And so this is a case of a 6-month-old boy brought into hospital from his mom, sick for a few days with a fever, cough, and work of breathing. He says he hasn't been feeding well, he's getting dehydrated. And so you do some oxygen saturations and they're 82% in this kid with some respiratory illness. So what would you do for management? Next slide, Nick. And so as in real estate, really it depends on location, location, location. So if you're at the Stollery, you might have access to fancy equipment, one of these resus rooms like the one that you see here on the left. And as Dr. Hawk said, the ability to plug in your oxygen prongs into the wall and get reliable oxygen for treatment of this child's hypoxemia. But if you're in the pediatric ward in Jinja Hospital in Uganda, which is on the right, you might not have access to the same level of equipment, and definitely access to oxygen can be limited, which is what really makes the outcomes different between low resource and high income countries when it comes to things such as pneumonia. Next slide. So just some statistics. So if you look at death rates from pneumonia in children under 5, you can see that the concentration of high mortality is really focused in sub-Saharan Africa, and as well as parts of Asia as well. And really these highlight sort of the impact of minimal resources on availability of oxygen in these settings, along with other cornerstones of pneumonia care, such as antibiotics and advanced sort of tertiary care. Next slide, Nick. So really getting into how big of a problem oxygen is. So pneumonia is the leading cause of child mortality under 5 globally, with over 920,000 deaths annually. Only 4% of these children in low resource settings get access to life-saving oxygen. At the same time, however, we know that reliable access to oxygen can reduce mortality up to 35%. So if we know that oxygen is such an effective intervention, why is oxygen availability such a so minimal in these settings? Next slide. And so just some more statistics, and some of these come from studies that our group has done as well in terms of oxygen availability and nursing capacity. So not only is pneumonia a leading cause of death in these children, when you look at actual functional oxygen delivery, so some hospitals might have cylinders, but they're empty, or concentrators that don't work. And so when we looked in Uganda, only 18% of pediatric wards had functional oxygen. 72% of sites have frequent power outages. So if they have a grid powered concentrator, that's going to go out. And most nurses, almost 100%, felt that children who needed oxygen didn't receive it. And 100% of nurses felt that they needed additional training. So in addition to the capacity of providing oxygen, it's also capacity of training in the use of pulse oximetry and how to apply that oxygen to patient care. Next slide. So it comes down to how we deliver oxygen. There's a few different points. So there's a few different modalities that are used in low resource settings. One of the main ones is cylinder oxygen. So this is compressed oxygen stored in a pressurized cylinder, and it's often the current standard of care in many low resource settings. It doesn't require power or grid access, so it's good for rural areas in that sense, but they're heavy, difficult to use, and they require regular refills, which is what makes it difficult in case you have a supply chain that can supply it out to those rural areas. Next slide. The alternative to concentrators is the alternative to cylinders, is grid powered concentrators. So these are off-the-shelf components that you can buy here as well. So oftentimes for home like COPD patients or things like that. And so they use a silicon sieve bed to concentrate oxygen from the ambient air. So these operate on their own. They don't need refills. They need minimal maintenance. You just flick a switch and the oxygen comes out. But they do require a constant source of electricity, and they can't function during power outages. And as I said before, over 70% of hospitals in these settings have frequent power outages. This graph on the right shows power output from the Jinja Hospital that I talked about earlier. And each one of those lines going down to 0 is a power outage over that 8-week period. So significant outages, and a few hours of no oxygen can cause a child to die. Next slide. So Dr. Hawks already chatted about this briefly, but even especially with the COVID pandemic, but even prior to the COVID pandemic, oxygen supply issues in these areas was making headline news. So power outages, poor oxygen supply causing the deaths of patients who otherwise could have been saved if they had reliable access to oxygen. So what we've developed as a team is solar oxygen. So what it does is it combines the free inputs of air and sun to provide reliable access to oxygen off-grid. So it uses solar panels going through electrical components, including a charge controller and a battery bank, which then powers an off-the-shelf oxygen concentrator. So what this means is that you're getting regular power from the sun, so you're not affected by power outages. And in case there's rain or cloud cover or anything like that, there's extra power stored in the battery so that you can sustain your oxygen use. And so this can last up to 72 hours off of batteries alone, or for up to 12 days during the rainy season. It has the same benefits as regular concentrators because it's easy to use and doesn't require regular refills. Next slide. So this is what it looks like in practice. You have solar panels on the top of the roof of the building. You have the electrical components, including the battery bank. You have the plug-in oxygen concentrator, and then that delivers oxygen to a child. Next slide. So we've been working on this for years now, and we've developed some evidence to show that it's effective. So we started with a proof of concept trial just to show that you can deliver therapeutic oxygen through this modality. And then we did a comparison randomized non-inferiority trial, comparing cylinders to solar oxygen, basically showing that it doesn't matter how you get your oxygen, as long as you have reliable oxygen, it's non-inferior and still sustainable. After that, we did a cost effectiveness study to demonstrate that solar oxygen is a cost-effective intervention. And now we've done our solar oxygen study, which Nick will talk about further, to look at whether solar oxygen actually is associated with decreased mortality. Next slide. So just briefly getting into these points. So the proof of concept, all we did was we set up our system, looked at metrics for children and saw that if you give them oxygen, their oxygen saturations improve, basically just showing that the system decides as we made it produces medical grade oxygen and works. Next slide. Then we did a non-inferiority randomized control trial where we randomized children to receive solar oxygen or cylinder oxygen. And we saw that there was no difference in outcome in terms of time to discharge between the different modalities. And there was also no difference in mortality or time to wean oxygen, which were our secondary outcomes. Basically, again, showing non-inferiority. It doesn't matter how you get your oxygen, it's effective. Next slide. And so these are just the graphs showing the mortality, time to discharge, and time to wean oxygen between the two groups, showing that it's equivalent or non-inferior, sorry. And then we did some cost effectiveness analysis. And so these numbers should be a little bit updated. They're slightly different now, but basically looking at how many dollars do you have to spend to improve outcomes. And so one standard metric that's used is basically a disability adjusted life years saved. So every year that you can save by an intervention. And so the DALYs that we have gotten are between $20 to $25 per life year saved. This is a very cost-effective intervention. Usually interventions between below $400 or $500 in this setting would be considered cost-effective. And you can see that the cost per patient treated or per life saved are also very low, just around $500 for life saved. And that's because once you set the systems up, the maintenance costs are minimal over the lifespan of the intervention. Next slide. And I won't spend too much time on this slide because I want to get on to Nick, but basically you want your sites to be ones that see a lot of pneumonia cases and have poor oxygen availability prior so that you can see the best bang for your buck. And that's what our sensitivity analysis shows, is that those are the factors that it's most sensitive to. With that, I'll pass it on to Nick to talk more about our current studies.
Thanks very much, Qasim. So like Dr. Meehan was saying, we've spent a lot of time trying to figure out, does the system work? How does it compare with other available modalities to deliver oxygen? And is it a cost-effective intervention? But the real question that we wanted to start digging into was whether or not the delivery of oxygen through our solar oxygen systems actually resulted in a decrease in mortality amongst children presenting with respiratory illness and hypoxemia. So to that end, the first real kick at the can that we took was implementing the systems in the city of Butembo in northeast the Democratic Republic of the Congo. And for those of you that are aware of the Democratic Republic of the Congo, it's not only an area of ongoing internal armed conflict, it's also an area with recurrent Ebola outbreaks. And what you'll see is that the solar oxygen team has a knack for being able to implement solar oxygen systems in some of the hardest to reach areas, including the Democratic Republic of the Congo and more recently in Somalia. In terms of what we actually did, first off was we did what's called a quasi-experimental before-after design, where in a nutshell, 2 hospital sites in Butembo were recruited. Patients would present to these hospitals, would be screened to make sure they were indeed hypoxemic, and then they would receive the standard of care. And then we would follow them throughout their stay in hospital and then would measure their survival data 30 days after discharge from hospital, 30 days after presentation. Then through May and October in 2018, we installed our solar oxygen systems and did the exact same thing in the post solar oxygen period, where patients presented to hospital, this time wards having access to solar oxygen, and then would again measure the survival data thereafter. In terms of what we saw, we were encouraged to see that the installation of solar oxygen systems was associated with a decrease in mortality, with about 60% of patients have 60% mortality pre-solar oxygen installation, and then that decreased to a 30% mortality in the post-SpO2 period, which represents a relative risk reduction of about 50%, which is impressive. The other piece that we found in some of our secondary analysis was that the installation of these systems were associated with a decreased frequency of interruptions to oxygen therapy. So in the pre-solar oxygen period, children would either have their therapies interrupted because they would experience a power outage, and the gas-powered generator that would be used to power the solar oxygen system would run out of gas. Or when a second child would be admitted to the pediatric wards, they would have to share oxygen between the two children, oftentimes requiring one patient to have oxygen removed from one and given to the sicker child. And then in the post-solar oxygen period, because we don't rely on gas-powered generators anymore, there were no interruptions from that. And likewise, the system is able to support 2 children at a time, and thusly we can share. Now, this is the limitations of this study were that it didn't account for some of the confounding effects of time. There wasn't a control group, and it was a relatively small sample size. So while we were able to conclude that SPO, the solar oxygen systems were associated with a lower mortality, we still had some additional questions that wanted to be answered. If you're interested in seeing more about this study, we can. You're welcome to see the published manuscript. So this brings us then to the stepped wedge cluster randomized control trial, which is the much larger trial that was being implemented, has been implemented in rural Uganda with more than 20 healthcare facilities and pediatric wards being recruited. And you can see from our map here that we have quite a spectrum of geographic coverage. And in this study, we're wanting to compare the 48-hour mortality in children under the age of 5 presenting to hospital with hypoxemia before and after the implementation of our solar oxygen systems, this time in 20 hospital sites. Now, as you can imagine, this is quite a big endeavor to be able to install solar oxygen systems across a number of different hospitals. And so we've leveraged something called a stepped wedge cluster randomized control trial design, which is a very modern study design that used in large scale infrastructure like projects similar to this, to the solar oxygen project, whereby the solar oxygen systems are installed on a stepped process month to month. And thusly children are recruited throughout the period and thusly go from being in the control group or the no solar oxygen group into the experimental group where solar oxygen is available. And what we see is that over the period of time since the summer of 2020, we've been able to recruit now our intended 2,400 patients. And despite this whole global pandemic thing, we've done pretty well in terms of being able to maintain our recruitment. Now, what you can see here on the right-hand side are some examples of the recruitment progress in some of the smaller sites, with the pre-solar oxygen period being the white portion of the graph, and then the post-solar oxygen period being in the blue part of the graph. So what we see is that at different periods throughout the study, for example, Kagadi goes from being having the installation of solar oxygen done right at around 2020, and going from the pre-solar oxygen to post-solar oxygen, with the majority of patients being recruited in the post-solar oxygen period. And then as the program, the study moves on, Karisizo and Bukadia have the solar oxygen system installed later, and thusly have more time spent with patients being recruited in the pre-solar oxygen period compared to the post-solar oxygen period. And ultimately, we see that there was a fair balance between the pre and post-solar oxygen period. As patients were recruited to hospital, we screened them to ensure that to screen them for hypoxemia, that is oxygen saturation of less than 92%. We approached the legal guardians for consent, and if the consent was granted, the child would be admitted to a ward with either solar oxygen present or not. The child would, if they didn't provide consent, they would still be admitted to the ward, but it wouldn't be included in the study. And on the wards, solar oxygen systems would be present or not. And then they'd receive their standard of care, and basic demographic data and clinical information would be collected. And at the end of the trial, we're comparing the survival at 48 hours after admission. So what we've seen throughout the study is that we've screened more than 70,000 children, of which 68,000 didn't meet our exclusion criteria, and ultimately we enrolled 2,400 kids in our study, 1,052 of which were included in the pre-solar oxygen period, and 1,353 were included in the post-solar oxygen period. And then, as I mentioned, we would measure the survival data in both of the groups. You can see that we had one unknown case where the outcome wasn't known, and for a bit more detail about that, the family left hospital on account, and the child was lost to follow-up. Ultimately, though, in terms of the actual data itself, we found that in the pre-solar oxygen period, there were 53 deaths amongst the 1,052 children enrolled, representing a 5.1% mortality rate. And then after solar oxygen was installed, we see that there were 38 deaths amongst the 1,353 recruited children or enrolled children, representing a 2.8% mortality rate. Now, this represents a relative risk reduction of 44%, which is in line and consistent with literature, other literature published in the area, which found that when improved oxygen systems are installed, there was a similar reduction of 35%. So these are impressive results coming out of the solar oxygen trial. And then, in addition to the actual primary outcome being mortality data, there's a plethora of other data that was collected throughout the study, providing a rich amount of information for additional studies in the area. And you can see some of the data points that we've collected here. So that's just a bit about our solar oxygen trial. I'll now pass on to Dr. Abdullah Saleh for some context as to how the project is being scaled.
Awesome. Thank you so much, Nick. And sorry I wasn't here at the beginning, but I'm Abdullah Saleh. I'm a pediatric surgeon here, and I'm also the CEO and co-founder of IC Change. So really the goal of that, what I'm hoping to talk about is to look at this amazing work that Dr. Hawkes and his team had managed to execute. But then now, how do we take that from a large-scale proof of concept and take it to scale? So obviously, having implemented in 25 sites is already a very large implementation, but it was still funded from outside. And now we need to look at how do we leverage some of our entrepreneurship and innovation so that we can make that locally sustainable. The key, though, is to make it financially viable, not dependent on aid and outside funding, and achieving sustainability and local ownership so that it's not relying always on people from the University of Alberta or from Innovative Canadians for Change to come in and play this role. But at the same time, that comes only by creating an impact and impacting livelihoods and have people have skin in the game of their own accord. And so that was really our scaling strategies, to working from that. How do we go about creating that lasting impact? How do we find the right people to empower and make local entrepreneurs? We would need to overcome a few hurdles to make that reality. And so Dr. Hawkes had, and myself both work at the same place, and he had approached me saying, they've done this work and they're looking for a vehicle to do this. And we had IC Change, which is a not-for-profit registered here in Alberta, and it's structured around 5 key elements. That we have a core team of people that have a lot of different experiences and live and work in multiple different countries. There's an innovation lab, which brings different groups from around the world and different experiences, but it really takes ideas that we see have huge potential for large-scale impact and sustainability, and we would invest resources into to take it from a proof of concept to scale. That's our goal. We have, as IC Change, we have an impact portfolio. We've done this a number of times with different technologies, from water filters to high efficiency stoves to medical records to different spinning off a number of different social enterprises, both in health education, in medical devices, and in software. And there's also an impact practice side of it, which is more on the consultancy side and leverages a big global network. Next slide, please. So in terms of a process, Usually how IC Change goes about doing that, and a lot of the work that Dr. Hawks and team have already done, is to take an initial design, initial idea, pilot test it, review the best practices that both have come up from that pilot, refine and expand, which is what, in my mind, the initial implementations had been doing. Pilot test number 2, which is the stepwise trial that was done. And then now we're really at step 6. How do we take this idea and amplify it? How do we take different approaches, different tools, different entrepreneurial endeavors, and different leveraging different existing avenues for us to be able to maximize the impact, at the same time keeping some of the experiences as competencies and a toolkit that we can share with other groups so that they can learn from these lessons. Next slide, please. So with that in mind, out of the innovation lab, and once the solar oxygen project, which is what this initiative was under the University of Alberta, and it got funding from Grant Challenges, we started to change the thinking to move more towards what you would consider like a startup. And so the transforming solar oxygen project into solar oxygen labs as a clear new entity, and it's being incubated under IC Change until it gets to a point where it can be registered in East Africa and to go and to function autonomously and to continue to grow and make an impact. In order for us to be successful as solar oxygen labs, we had to define the product, the market, the customers, and really the value proposition. What are we bringing? What is the gap? What is the pain point that we're trying to address? And how do we develop a business plan and strategy around those pain points? Now, currently the system, as was explained, is made up of pieces and tools that come from off-the-shelf parts that are easily and readily available to people, but they're put together in an innovative way so that they can provide impact. And that's really the minimum viable product that you need. But the price point is still quite high. So how do we go about identifying what this minimum viable product looks like, and how do we keep the quality, keep the impact that it makes, but bring down the price point? And how do we go about implementing locally, as in both the installation, assembly, support, and the manufacturing of all that? Next slide, please. So from the innovation lab point of view, and from our goal is the end goal is successful business transformation to create impact. And I use the word business, and it's always a bit of a cringeworthy word in the global health or global development work. But as Dr. Hawks and Nick and Kasim and I will all agree that really we've come to appreciate the importance that this has to be sustainable. This has to have a customer base behind it that they can put money towards that, both to show that they're interested and that they're committed to this, but also because the funding from outside is finite. And then after that, these projects invariably will fizzle out if there is no clear adoption with a clear business strategy. So it starts out with shaping the clear value strategy for this. Like what are we trying to, what pain point we're trying to address? How do we become fit for growth? How do we go about registering the right vehicle? How do we solve our technical problems? How do we come up with a product that is viable for people? And how do we engage the right partners, the right people, the right technical people? Like 4 or 5 people in Canada that are in the medical field are not sufficient to be able to do this. Now, of course, the team in Uganda is very experienced in doing this. How do we now build up even more of those skills and identify more people to be able to make that a local sustainable enterprise locally? And finally, how do we integrate technology, even with monitoring our own system, so that we can start to make better informed decisions in terms of where to invest our time and how do we go about making this product more financially viable for people. Next slide, please. So I think, taking a kind of a big bit of a step back to look at the oxygen ecosystem, that this is kind of more in general, but this looks at it from a global health or development perspective. And this came from PATH, which is a large organization that deals in the global health sector. There's 4 main things when you're thinking of a supply chain of any product. It's production, storage, distribution, and delivery. There are, for oxygen, there is a number of different ways that you can get oxygen. You can get bulk liquid oxygen, commercial oxygen with air separation units or ASUs, and then the more at the facility level, you can have PSAs or pressure swing adsorption. Then once you've made those, made that oxygen, it's typically either a centralized process that puts in the oxygen in a cylinder, then you distribute it, or a hub and spoke model where you can store or make locally and distribute in a network fashion, or you deliver bulk liquid oxygen. But all of these things come with different technical challenges, and you need high pressure canisters. You need to be able to store liquid oxygen, and that involves a lot of pressures and a lot of electricity to be able to do that. All of that to be able to get bedside cylindrical oxygen to the patient. Or you need a manifold that's able to plug in the different cylinders and it can pipe oxygen to the different rooms. So you can see how complicated all this is and why ultimately for most of the oxygen interventions that happen in the developing world, it ends up focusing in the urban center. So this solution that the team has worked on is really looking at how do we deliver oxygen to the sites that, like how do we further the reach of oxygen to the patients further down, and how do we impact the centers or the facilities that are both, that don't have access to consistent oxygen and also don't have access to consistent electricity. So combining continuous oxygen availability as well as electricity problems is what the beauty of this intervention really is. Next slide, please. So, like I said, this product really tackles two main things: oxygen availability as well as electricity, and electricity provides that with something that is quite abundant in around the equator, which is sun power, but the cost of these solar panels is still quite prohibitive. Next slide, please. So in terms of defining our market, what is the marketplace that we're targeting? And the team has already spoken about Uganda and Somalia and DRC. And we looked at how many regional referral hospitals there are, how many national referral hospitals there are, but most of those big centers already have their supply chain of oxygen secure. We're sitting and trying to deliver oxygen to those that are that don't have consistent electricity and don't have continuous oxygen availability and don't need massive amounts of oxygen that would require their own plant. So it's quite a niche, and that's what I mean by determining what your value proposition is. That's the real niche area that we're targeting. It's where solar oxygen sits. It's at the intersection of these two rapidly expanding markets, oxygen and solar. But unfortunately, these, while they're growing, they're still neglecting a big portion of the population that needs it. So solar energy in Africa is growing at a rate of 8% annually and is expected to increase by 2040. COVID has obviously demonstrated the gaps in oxygen access and has made it even more severe. And this work obviously preceded COVID, but it's just been accentuated. And now there is big expansion opportunities in East Africa using the national oxygen scale-up plans. But even when you look at those scale-up plans, they still focus primarily on, and I'm sure Dr. Hawks would talk more about that, but focus more on central, power oxygen plants that are able to make oxygen more central. Next slide, please. So in terms of the target customers that we're looking at, there's four main types of organizations: the not-for-profits or faith-based organizations that would potentially be able to buy these systems for their patients, the private or for-profit clinics that might have the financial means to be able to pay for that, intergovernmental agencies like WHO and UNICEF, they have large-scale programs, would be able to buy a system like solar oxygen, and then public sector organizations like ministries of health and public health administrations that might have money if they're allocated in their budgets, but often would say that they don't have any money. But you can see in that there are a lot of different players that meet that criteria of which health centers would be able to, would need this system, but getting money to pay for a system like this is still quite challenging to get money from these customers. So how do we go about making that a more feasible reality we believe that scaling this up is by understanding how to bring the price point down, how do we make the technology more available, and how do we break down these products so that we can show value at every turn. Next slide, please. And so when you look at if Solar Oxygen Labs is to run and to be successful as an organization and to be able to continue to make an impact, it has to run like a business. And the way to scale that is by looking at the different 8 service offerings or goods and services that this organization would offer. So the first is a needs assessment. Very few groups have as deep of a domain knowledge in this area as having implemented in 25 sites in some of the most austere environments, war-torn, with Ebola outbreaks, or just being able to navigate the bureaucracy. And that should really applaud the team for all the work that they've managed to do. To be able to do a needs assessment for various organizations that may be able to avoid having to develop those expertise on their own. Sourcing and assembling the tools to be able to do that is another skill set. Data and analytics, which we'll talk a little bit more about in the next few slides. And then there's a number of different things here, like if you break down what the system actually is, you have solar panels that are generating electricity and then oxygen generating equipment. Both of those are providing what you can think of as utilities. If you think of oxygen as a service, you're making oxygen and you're making electricity. Both of those are, if they're being made in real time, you can use them or store them. And they have value, and they have both from an impact point of view, but on the marketplace as well. So how do you go about, if you're trying to scale this, if you're investing $10,000, $15,000 per site, how do you then go about maintaining those? How do you go about using the electricity and oxygen that's being made to be able to create the maximal impact? Next slide, please. So this is what I mean by data analytics. This is slides that Dr. Hawkes had provided. Just looking at some of the monitoring of the systems, you can see that this is energy from solar panels, and you can see a fair amount of energy is being generated from this daily. At the same time, the power outages that are happening, this is over the span at the bottom axis, and the second panel, you can see that there has been 6 big power outages in the last like 3 weeks or so. This is last year's data. So there is a surplus in terms of electricity that's being generated, and that has value. And so that if you're trying to offset the price for a hospital to say, okay, well, you're generating electricity that could be used for potentially other things, but also you're generating electricity or oxygen that could be used in other ways, and that can help over time bring down the price. So the strategy for scaling these things up is to look at every part of the network, from the patient to the hospital to us being able to deliver the service as part of a network of a supply chain of information, a supply chain of goods and services. Next slide, please. So with that in mind, if we started to conceive of an idea that tries to bring oxygen closest to those that need it. And this is a typical hospital or health center and sub-district hospital in Uganda or in Kenya that looks like this, where they are overwhelmed by the number of patients that they see. Their electricity access might be insecure. But that's their reality. And if we're able to generate extra oxygen, we might be able to compress it in our plants. And one of the partners that we're working right now is LeanMed, is looking at compressing some of the cylindrical oxygen or some of the concentrated oxygen that we're making into cylinders, and then be able to supply them to further smaller centers that creates even more reach for the product, so that you're not just using it at the one hospital, but you're using it more and more further down. And one way to deliver that is on the back of these motorbikes, like what they call Boda Boda, or little motorbikes that are able to broaden your scope. Next slide, please. So the main goal really of all of this, and like I know we're talking about some very large concepts, is to improve affordability. Because if this system is to make an impact for those that are invariably going to continue to be neglected, even with the new national oxygen plans, the idea is to make these technologies affordable and readily available for these people. And some of the ways are by improving the technology, driving down the price point, bringing these clinics as almost franchisees within these systems so that they can help generate some of their own revenue to offset the cost of the system. Next slide, please. I won't spend too much time on this, but there are a lot of different financing options that we look in terms of scaling this, and you can go from rent to own to institutional financing, or NGOs or private health facilities can just finance it, or just outright purchase it if there are grants, things like that. But at the same time, you also have to think about, it's not about just the capital expenditures of putting the equipment in. How do you go about maintaining it? How do you go about putting not just the installation, but the maintenance of that? Next slide, please. So with that in mind, one of the contributions that IC Change is bringing to this initiative is this manufacturing space in Kenya, and an entrepreneurship academy that's nearing completion just outside Nairobi. And our goal is to assemble initially all those solar oxygen systems locally in Kenya, both to improve the local capacity, to drive down the cost by being able to warehouse these in place, and then to start to innovate on the technology itself. So if you're taking products off the shelf, they will have they're more expensive than buying them in bulk, but also to be able to bring down the price point further and the efficiencies further by working on them under a single electrical system or a single backbone that you can plug a lot of these things into. And so that's what this manufacturing space is, which is coming online shortly, is doing. And you can see that there's an administration building, a research and design building, a lot of manufacturing factory space, and some accommodation that's planned in the future, but we don't have to spend too much time. This is just some of the renderings from the architects that have been sent over, and we're putting up the roof now on this. That's the stage that we're at right now. This is just another closer picture of the renderings. Next slide, please. Perfect. So I'll stop here and hand it over to Dr. Nyende.
Great. Thanks so much. Thanks so much, Dr. Saleh. I thought we could close just with 2 to 5 minutes with a quick little interview with Dr. Saleh Nyende. Dr. Saleh, can you, can I see the video here? Yes, good. So he's got this video on, he's got his mic on. So welcome. Dr. Saleh is a Ugandan pediatrician, so I thought we could get the word from the horse's mouth. So Dr. Saleh, can you begin by telling us what you're doing here in Edmonton?
So I'm here pursuing a fellowship in pediatric nephrology, and it's a 2 years training program. And hopefully after that, I'll be able to practice pediatric nephrology. Yeah.
How many pediatric nephrologists are there in Uganda?
Currently, there are 2.
2 in a country of 30 million?
40.
40 million, yeah. Okay.
Yeah.
So we have more pediatric nephrologists at the University of Alberta than the country of Uganda has. Yeah. So Dr. Saleh, can you tell us where you work in Uganda before coming here?
I was working at Jinja Regional Referral Hospital, and then also doing some private work in private hospitals, because we have a hybrid system of public health facilities and then the private health facilities. Yeah.
And the audience did see some pictures of Jinja Regional Referral Hospital. So that was the one with the fairly crowded peds ward there. And Dr. Saleh, can you give us a story? I thought maybe you could just very briefly, because we don't have a lot of time left, but maybe you can tell us from your both professional, but also you also have a personal story about oxygen availability, because your own son had bad case of pneumonia when he was little. I wonder if you could tell us about both your professional and personal stories around how easy is it to get oxygen in Uganda?
So oxygen availability, especially for children, is a big issue, because most of the adults tend to opt for the private health facilities where they can be able to access the oxygen, and that costs around $100 to $500 per day to get that oxygen therapy. However, for children, people are more lenient. As you know, children are dependent on adults, and people always try to give them the best care. And in our public health facilities, the numbers are overwhelming of children who need oxygen day by day. And sometimes some of them are taken off early in order to accommodate those who are very sick and who need urgent oxygen therapy. With minimal improvement, they are taken off to create more space for those coming in and are very hypoxemic and sometimes deteriorating into shock. Yeah.
And what about your own son? Because your own son Sahal had a problem with pneumonia when he was little, and you had to go searching for oxygen.
Yeah, so he was delivered normally, but then after like 12 hours, 8 to 12 hours afterwards, he became tachypneic. And at that time, no one was around, but I, being a pediatrician, decided to take a look and check on him. And I found out he was breathing quite fast. His minimum respiratory rate was 100. So he was oscillating between 100 to 120 breaths per minute. And then I had to call the nursing staff, and this is a private health facility. They came over and did oxygen saturation using the pulse oximeter on the finger. And he was hypoxemic at 86%. We started him on oxygen therapy, and his SATs initially went up to 92, but progressively he was becoming more dyspneic and requiring increased oxygen support, initially on nasal cannula, and then we had to ramp it up to a non-rebreather, but still with no improvement. And then we had to go to the bubble CPAP because electrical CPAP is mainly in the private institutions. And after 3 days, he was just getting worse, not responding to all forms of oxygen therapy. Then I decided to take him to a higher end private hospital. And they were able to access the electrical CPAP. And then they also had a neonatal ventilator. And those are very rare in Uganda. I think in the whole country, there might be like 3 or 4 neonatal ventilators. Most of the high-end hospitals have usually 1 vent which can accommodate a neonate. Yeah. And subsequently, he did well when we were over there. He was on CPAP at 6 liters per minute, but they were able to win his FiO2 to 21%, and he gradually improved over 5 days. However, it was at a great cost, because I was paying in between $300 to $500 daily. And of that, the oxygen fees was around $200 daily. Yeah, and monthly payment for a doctor, the highest earners in public service is around $1,000. And imagine you have to pay $200 to $500 daily for healthcare. Yeah.
$1,000 per month.
Yeah, per month.
And yeah, thank you so much. Thank you so much for sharing that story, Dr. Saleh. Our time is short, but I thought it was great for the audience to hear hear your own personal and also professional story about oxygen and just how expensive it is and how you have to access private facilities. Now, if you consider that Dr. Saleh is kind of maybe, if I may say, Dr. Saleh, you're at the top of the quintiles of socioeconomic status in Uganda. Imagine if you're from the bottom socioeconomic, there's no hope of being able to pay for oxygen. And so children born in the village, so to speak, to someone who's earning, say, less than $5 a day, this is completely out of reach. So yeah, so just to show you just how expensive oxygen is and how scarce it is in these settings, how you have to access private healthcare, and only the Saleh, you know you're not the wealthiest, but only the wealthiest in the country can do it, and only the most resourceful, educated. This is a pediatrician, right? That needs to pull every lever at his disposal to get oxygen to save his newborn child. So the situation is I think we can say dire, right, Dr. Saleh, for anyone other than the very best educated and the very wealthiest.
Yeah, and it was even worse during the COVID-19 pandemic, because we had a peak, I think in June, July last year, and they had to withdraw all the oxygen cylinders from the pediatric wing, because on average, each adult COVID patient was using 2 cylinders at a time. And then we were left only with the oxygen concentrators for the pediatric patients, and with frequent power outages, including during the rainy season, it becomes unreliable, and this makes solar oxygen very, very important.
Great. Thank you. And Dr. Saleh is an unabashed advocate, but he was also the trial pediatrician in one of these studies. So just he's biased, but in favor of but we like it too. So thank you so much. Thank you so much, Dr. Saleh. And with that,